Hi, I'm John Atkinson, one of the neurosurgeons at the Mayo Clinic, Department of Neurosurgery, which incidentally happens to be one of the largest neurosurgical divisions in the world. Hyperhidrosis is an interesting entity that we've been managing here in the Department of Neurosurgery for over 70 years. In fact, one of the founders of our department, Alfred Atkinson, had been operating this back in the early 1920s. The reason hyperhidrosis is of interest, it probably affects about 2% of Americans, although most of them do not know it. The ones that come to attention are those that have severe cases, and the ones that have surgical access, that is, have a surgically treatable lesion, are those that have a specific entity called palmoplantar essential hyperhidrosis. That is, there are lots of reasons why an individual may sweat. You can sweat vigorously with exercise, you can sweat because you're nervous, you can sweat for a lot of different reasons. But total body sweating is generally separated from hyperhidrosis. And hyperhidrosis comes in two forms. There's a craniofacial variant, where only the cranium and the face sweat, and they can be sweating with stimulation of food or anxiety or excitement or something like that. There's really not a good surgical option for that specific variation on hyperhidrosis. The one where surgery is really targeted is palmoplantar hyperhidrosis, and it specifically affects the hands themselves. We have our best results at drying the hands. In fact, the hands can be so dry after a surgical therapy of treatment for hyperhidrosis palmoplantar that you'll have to lick your fingers to turn page or count money. There will be no moisture there at all. We're less successful with the axilla and feet. However, they do respond in a general measure. Decreased sweating in the axilla and decreased sweating in the feet. However, the operation is designed for hyperhidrosis primarily of the hands itself. And we're very successful at that. The medical treatments are generally insurance modulated. That is, if you had hyperhidrosis palmoplantar, it could be quite severe, but they generally would make sure that you had tried other medical therapies first. So in part of the workup for this condition is to be seen by a good medical neurologist and or dermatologist to treat the condition medically, and there's some good medical strategies for that. And they're interestingly in the dermatology realm for axillary hyperhidrosis. If your armpits sweat more than your hands, and that's where you would really like treatment. If you failed medical therapy, such as just stronger antiperspirants and that sort of thing, then there is a surgical therapy offered by dermatologists for axillary sweat gland removal through a curettage method, sort of like liposuction. That actually works fairly well for the axillary component. So it's essential that you be managed by somebody in the medical field, either neurology or dermatology first. And if all things fail and your case is severe enough, be referred for a surgical therapy in the aftermath. Surgery is generally, as I said, targeting the hand part of palmoplantar hyperhidrosis, and almost everyone who does the procedure today does it through an endoscope, through the chest. A small incision, generally one. We use a uniportal system here, that is one incision, one endoscope, does the whole procedure through a centimeter-long incision in the high portion of the axilla and the armpit, but other centers may use 2 or 3 ports, depending on the surgeon and how experienced they are. Interestingly, most people for the last 60 or 70 years have been doing sympathectomy, that is, removal of the sympathetic chain. We have developed a procedure here to be different. It targets the same sympathetic nervous system, but we cut the sympathetic chain. We do not remove it. And as a sequela, we get the same success that the larger operation gets. But interestingly, we've been able to avoid a sequelae of side effects that most patients find very disagreeable. For example, in the traditional sympathectomy, that is, taking out the chain itself through an endoscopic approach to the axilla, removal of the chain, in somewhere between 5 and 20% of those patients, they'll have sweating occur elsewhere on their body that is worse than what they had. For example, sweating in the crotch area, soaking through your pants in the aftermath of the surgery, that causing you to either wear diapers, adult diapers, or changing your pants several times a day, you would find disagreeable, probably worse than your hand sweating you had prior to the operation. That might be one of the corollary of doing the sympathectomy itself. To date, the way we've been doing the procedure, which is simply cutting the chain through a very small incision in the chest, we've managed to avoid most of the major complications. In fact, we have not had a severe case of compensatory hyperhidrosis, like I just described to you in the pelvic region in the aftermath of surgery. We have not had a severe case of that doing the procedure the way we do it here at Mayo. So it has been an exciting field for us, and it's constantly in evolution. We're having experimental protocols set up for younger patients to see does it affect their heart rate in the aftermath. So far, to date, the minor procedure we perform here does not affect an athlete's ability to perform marathon, distance running, or any other athletic endeavors. So it's been an exciting venture for us. There are many of my colleagues involved in that field, both neurology and anesthesia, who have an interest in this area of sympathetic nervous system. Mayo Clinic is a very large practice in sympathectomy, and that would be on all 3 campuses. We've managed to tailor our procedure to a smaller endoscopic approach, a limited sympathotomy instead of sympathectomy. We get the same success rate as a larger procedure, and thus far have avoided the complications that we have in the other larger procedures, so we've been very happy with our outcome thus far. We have a lot of research going on, specifically the skin methodology, cardiac input with sympathetic nervous system, both before and after. We're also interested, is there a surgical variation for the craniofacial variant? We have not to date been able to predict craniofacial sweating very accurately. However, there is research going on at the present time to see if we could develop a surgical procedure for the craniofacial variant, which heretofore we have not. So it's an exciting venue for us, both from the pharmacology standpoint, but also the physiology of how the body responds to sympathectomy, but also targeting future nervous system responses, both from the blood flow, say in migraineurs, or vasospasm from subarachnoid hemorrhage, but also the other craniofacial variation of hyperhidrosis, which heretofore we have not had operations for.